Thank you very much, chairpersons. And there were some comments from the chairpersons. You know, three chairpersons have a lot of hair, and then they were mocking the first three speakers, including me, Vaswani, Dr. Ramchandran, and myself. They said first three speakers have no hair. Okay, so I thought I'll just start with this photograph. And Dr. Ramchandran, you have also not seen the photograph, sir. This should have been the introduction to your next speech, but then I thought, well, Dr. Ramchandran has spoken about the art of diabetes because, you know, after spending 30, 40 years, what happens to all of us is we lose hair, but then important thing is, I was there, I had a lot of hair, okay? And that's Dr. Ramchandran. Lot of hair, right? And I don't have Aswani's photograph of younger days. Okay, and anyway, this is a photograph from 1989 batch, Diabetic Research Center at Chennai, and Dr. Ramchandran has been my teacher, and Professor Chief is also there, and I think I'll just move on to the next topic after that photograph. I think this is the title of my talk, right? At primary care level, smart combos went to intensify and budget. Kind of disagree with the scientific people because I have to start by really discussing the primary care part of it. Okay, we all are doctors. Now, complications of diabetes affects all. Does not differentiate between the poor and the rich, urban and rural, educated versus the uneducated. So today's approach, whatever level of care you are giving is going to be comprehensive. You have to be a lifestyle coach, you have to talk about diet, you have to talk about exercises and coping with diabetes distress, and of course the medications. The problem now is, let's understand one important fact. The complications do not discriminate. Should treatment be differentiated? Are we going to have two compartments, primary, middle, and tertiary for diabetes? This is something that we have to decide. It's one of the few diseases which silently crosses every social boundary. Does not ask whether a person is rich or poor, or urban or rural, or educated or uneducated. 1.3 million, and then it's rising in India. The complications, especially the ones microvascular, macrovascular complications, can develop in any person. And diabetes, if not detected early and managed, can have a huge impacts, all sections of the society. So the important thing that we must now realize is, we are all in primary care. The tertiary care actually means now complex cases which needs end-stage renal management, cardiac intervention, laser therapy, vitrectomy, anti-VEGF treatment, probably limb salvaging surgeries, peripheral vascular interventions. This is done at the tertiary care levels. All other things has to be done at the primary care level itself because diabetes does not discriminate. Nobody should say that I'm at the primary care and then therefore I can only do this much. So the primary care versus tertiary care differentiation is logically necessary for government purposes. People who are actually making some important policies, but ethically it's a failure, especially for a disorder like diabetes. I don't think there should be any primary care, tertiary care. And this is exactly what I wanted to say. The goal of each one of us should be equity in quality with appropriate referral according to the need. So having said that, primary care very clearly does not mean inferior treatment. Diabetes is important. It is a comprehensive treatment. Each one of us, if we are going to treat diabetes today, we have to be equipped with everything. And then I made it clear what tertiary care is. So today diabetes is cardiometabolic, renal and vascular in approach. There was a time when there were 3 eras. The first era was only glucocentric, went on till 2005. Then we had the gliptins, and then we said, okay, no hypo, no weight gain. And then 2015 onwards, when once we got SGLT2, it was very clear the end organ protection with focus on cardiorenal outcomes. Right. It doesn't end there. Now we are in the 4th era. The obesity management has become the 4th dimension. And we have the data. We know what is the problem with obesity in India. Right? And then I was listening to Dr. Krishna Sheshadri's talk on mitochondria, how it gets affected in diabetes, how we put on weight and things like that. Let's realize that the 4th dimension is absolutely real, and we should take it up very, very seriously. And obesity is more common in women. Lots of reasons, but then we have to know that it is more prevalent. Even urban areas, rural, this difference slowly will narrow down. Right now, this is the data that I took from NHFS 5 survey. There appears to be a difference in obesity between the rural and the urban population, but then slowly this will actually disappear. I don't want to even talk about this. Diabetes management in India, the budget is not a problem any longer. We have the best of the medications at very, very affordable prices. In fact, when somebody from a village comes and says that, sir, I don't have the money, I just tell him that, twice a week you end up having drinks. If you don't have drinks one day, probably you'll be able to pay for your diabetes. And there was a driver who would smoke 3 cigarettes. I asked him, nowadays you are spending 50 rupees on your cigarettes. Just stop that and you can afford your diabetes treatment. So there's no need to talk of budget with respect to medication in diabetes management. We have generics. We have fantastic generics. We can have a discussion about the originators and generics, but the fact is we have generics and it is affordable. The Western world will talk about the budget. I don't think India will talk about the budget. I think the next discussion point that we should take is, at primary care level, what are the smart combos? Well, Veervani did touch a few of these points. Let's understand these fixed drug combinations or combos, what we call as, it's for compliance and convenience and to reduce the pill burden. Even I find it very, very confusing when it comes to brand names. And many FDCs are irrational and contain lesser dosage than what should be prescribed. We as doctors, I think we must be very, very careful before we write an FDC, because you decide what are the drugs that you need in your FDC, what is the right dosage of a particular medication, and then decide on what you want to write. Just don't write because there is pressure on you from the pharma industries to write a particular FDC. You decide what you want to write individually and then see if it can be fixed into an FDC. Let's start with the useful combos. Well, one of the best combos is going to be an SGLT2 with metformin. Well, we all know that in full dosages. So you decide what should be the dosage for your patient. Then we have SGLT2 with metformin. And then, of course, a DPP4, right? Whether you want a JAPA or an EMPA is up to you. And what dosage of metformin you want. And then whether it should be sustained release or not. You want a sitagliptin or linagliptin or a vildagliptin. These combos are available, right? And if you want to use it, you decide what you want to use. And then you decide which combo do you want to use in this. Well, Lina and EMPA probably is a great combination. No need for dose reduction in CKD. Other DPP4s with SGLT2 must be used with caution, especially if there is CKD. Then you need to know how to readjust the dosage. Well, we have glimepiride with metformin, great combos, glyclazide with metformin. Then we have glimepiride with metformin and pioglitazone, still extremely useful. But you need to decide on what type of patients you are using it. Well, the government reduced the dosage of pioglitazone from 15 to 7, from 7.5 dosage has been taken off. You still get 15 mg with glimepiride and metformin, still very, very useful in certain patients. I think my personal choice, if it's a 3-in-1 combo, especially for compliance, and one set of patients who say, I don't want too many drugs, just give me one tablet, fine. As Dr. Ramchandran was saying, sometimes you just have to lie to them and say, okay, I'm just giving you one tablet. I think this is something that I use because I don't have to worry about altering the dosage if they want a 3-in-1. And then if you want to intensify, you can always add a glyclazide or a glimepiride separately. You can also add on insulin to this particular combination. Remember, diabetes is cardiovascular and renal benefits, so it's not just for the sugars. So SGLT2 kind of becomes more or less a permanent member of most of your prescriptions. And off late, for the last couple of months, semaglutide once a week to avoid insulin in patients with obesity or high visceral fat, MASLD, even if the BMI is less than 25. Because once you do a body composition analysis and if you see the visceral fat is high, I don't worry about the BMI part of it at all because BMI has a lot of problems. So you can straight away use semaglutide, and many endocrinologists are moving into this area where you have an SGLT2, then probably you have semaglutide because it's inexpensive. Okay, that's one of the reasons. But before semaglutide is used, of course, make sure that there is no diabetic macular edema or advanced DR, gallstone disease, pancreatitis, which all of us have to do as doctors. The do's and don'ts, contraindications, indications is something that we all have to learn, and we have to learn today. Because if you want to take care of the patient for the next 30 to 40 years, you have to be equipped. One of the assumptions that we all have is the primary care lacks facilities. Yes, some of the government primary health centers may lack the facilities, but really the assumption has been overturned. I have been actually going around trying to see some of the PSCs, especially close to Bangalore. I think I have to now change my opinion because the biochemistry lab is there and you have the ECG machines and you have the chest x-rays. It is available. It is just that the doctor sitting there must talk to the lab technician and start using these things. It's also available in Chennai, I'm sure. A good clinical examination can easily diagnose diabetic polyneuropathy. We can do it with a good history, good hands. That's not a problem. Good clinical examination, handheld Doppler can diagnose peripheral vascular disease. So one major complication. ECG is the best thing that we can have. We know it's not perfect, but then we can't have an angiogram in everybody. That we leave it to the tertiary care. Now the next two questions is fundus evaluation a problem? Okay, now I have to talk about this because 2 days back, I'm not showing you too many this one of this. This is made by a group of nanotechnology department at IASC, and then it's already available, and in the next couple of months everybody will start hearing about this. This is beating the competency of the multinational glucometers that we presently use, and you can do HbA1c, blood glucose, hemoglobin, and this one. Government of Rajasthan, government of Karnataka and one other government have given them 2 crore strips order. In fact, they're actually finding it difficulty to now supply. The cost of the blood sugar strips will be less than 5 rupees, HbA1c less than 50 rupees. They have a lot of publications, well validated. They're also going to be taking it to the rest of the world. So we should not just think that what is made in India is not okay. I think some of these things are going to break all the barriers. Now coming to the fundus part of it, Remedio's FOP with AI is known. It has 3 important things. The world's first FDA approved device to detect diabetic retinopathy, age-related macular degeneration and glaucoma in less than 10 seconds. And the Meteor's AI validated across multiple clinical studies worldwide and published. Cost less than 3 lakhs. So the government already has put it in. Kerala government, now it's there in all the government hospitals in Kerala. If not the government hospitals, if there is a private practitioner in a rural area, I'm sure one should be able to afford it. And this is what it's going to look like. You will have everything that you need for comprehensive care for diabetes. You just need to have that interest. That I'm doing something different, I'm doing something right. You need to spend time, and this is what it is going to be. So the disease is equal. Access to care should also be equal. It is. Only thing is we have to adopt it. Let's remember diabetes affects all sections of the society. Complications are going to be the same. The challenge is not who gets diabetes, but who gets the timely care. Different care levels are accepted, but different care standards are definitely not accepted. And healthcare should not discriminate in dignity or essential quality. Ladies and gentlemen, the primary care must be strong and accessible. Tertiary care should support complex cases. Referral systems must be timely and effective. The responsibility now actually rests with all of us as physicians to master the art of treating diabetes, the way it has to be treated, the way in which the best of the doctors in the world are treating it, and then we just need to train for this. Thank you so very much, and with that I will just stop my lecture.